Okay, we're going to wrap up Chapter 8, Joints. This will be Module 2 of 2. So as is often the case, I'll share my screen here. We'll go right to the PowerPoint. And we're going to talk about some examples of diarthrotic synovial joints. Most of these are diarthrotic. And we'll also wrap up talking about some specific joint movements. So this will be a very short module. So in the previous module, we talked about, again, the three structural types of joints: fibrous, cartilaginous, and synovial. And we described some examples of each of those. So again, we're shifting to the third and last type, synovial joints, most of which, again, allow free movement. So we use the term diarthrotic to describe that. There are, I believe, 6 different types of synovial joints. So let's start with 2 of those, which you see here, of course, pivot and hinge. And we've talked about the pivot joint when we were describing the 2 cervical vertebrae, C1 and C2, which, if you remember, were the atlas and axis, respectively. C1 was atlas, C2 axis. And we see here, of course, the interaction of those 2 cervical vertebrae, with the atlas being superior to the axis. Here we see where the occipital condyles articulate with the atlas. But what we're really focusing on with respect to the pivot joint is this vertical protrusion of the axis called the dens or odontoid process, which sits up inside the spinal foramen of the atlas. And when you go to turn your head or pivot your head from side to side, we described in lab how the atlas will move with the occipital bone of the skull, but the axis and all the other remaining vertebrae stay in alignment. So this is an example of a pivot joint where we have rotation. A hinge joint, think of a hinge of a door, because I think that sort of describes this convex surface of one bone fitting into the concave surface of another bone. And they're telling us to look here in the elbow, although we can find it also between the phalanges, the finger bones, same idea, hinge joint. So we've got, obviously in this case, the ulna fitting into the humerus. Think back to our description of those various structures, the various fossae and condyles. And so we have movement, in this case, in a single plane for the most part. We might also describe the knee as a modified hinge joint, as well as the 2 we see listed here. We only have movement in one plane. A saddle joint, we don't have a lot of examples of saddle joints, but if we look between the carpal bone here called the trapezium, now we didn't learn the various carpal bones in lab, so this may come as a new word to you, but this is one of those carpal bones. And where it articulates with the first metacarpal of the thumb is where we find a saddle joint. And it gets the name saddle because if you look at these concave and convex regions that articulate with one another to form the saddle joint, it sort of looks like a saddle, if you use your imagination, almost like 2 saddles, one fitting inside the other. And you can get a variety of movements if you think about, you can get rotation, you can get partial rotation anyway, you can get flexion, extension. We'll be talking more about those movements in a few moments. But think of this particular region here to provide an example of a saddle joint. We're now moving a little more distal from the saddle joint to where two bones here, one of the metacarpals of the hand, articulate with the first phalange of the, and they're using here the middle finger, but we could use any of the other bones here, if you will, to talk about a condylar or ellipsoidal joint. So we're in the wrist. This is the metacarpals. Here's the carpals this is the palm, I'm sorry. Here's the wrist, carpal bones of the wrist. So these are the palm bones, if you will. And we're looking at the second metacarpal and the first or primary proximal, I guess is the proper term to use, right? Proximal phalange. There'd be a middle and a distal as well with these four fingers. The thumb, remember, has a proximal and distal. There's no middle phalange. So anyway, where these come together, we would see the ovoid condyle of one bone fitting into the elliptical cavity of another bone. So there's a good place to think of a condylar or ellipsoidal joint. Tells us also to look here where the distal end of the radius articulates with the carpal down here. We'd have another example of an ellipsoidal joint, allowing back and forth and side to side movement, as is illustrated by that little sketch. And our last two examples of synovial joints, the ball and socket and plane or gliding joint. The ball and socket, we immediately think of the articulation of the femur and the coxal bone, although we could also talk about the head of the humerus and the glenoid fossa or cavity of the scapula as well here in the shoulder. But the hip is probably the most commonly thought of ball and socket joint, where we have the head of the femur fitting into the acetabulum of the coxal bone. Remember, the hip or coxal bone is really made up of three fused bones, the ilium, the ischium, and the pubis. So this gives us our most broad, widest range of motion of any joint, as it mentions here, the ball and socket joint. And finally, the plane or gliding joint is telling us to go into the carpals or into the tarsals, and we will find this gliding joint where we have an almost flat or slightly curved surface of one bone articulating with a fairly flat or slightly curved portion of another bone, allowing for twisting and back and forth movement. You might also remember we talked in the previous module about one particular type of synchondrosis cartilaginous joint, remember, which was between the first pair of ribs and the sternum. But we said that the remaining pairs, number 2 through 7, were different. Yeah, and so here is what we're talking about, a plane or gliding joint between these pairs of ribs and the sternum, where the cartilage articulates with the rib as well as where it articulates with the sternum. We would have a plane or gliding movement. It also mentions the sacroiliac joint, which again we talked about in lab, where the sacrum and the ilium articulate with one another. So there's a variety of examples of where we can go in the body to find plane or gliding joints. And here we see a review of the 6 types of synovial joints. Let's talk about some different kinds of movements related to these diarthrotic synovial joints, starting with this pair of terms, abduction and adduction. Technically, the process of abduction is where we move away from the midline of the body. So imagine the body, anatomical position, right? If we were to move our leg off to the side, as is illustrated here in this diagram, or if we were to have our arms at our sides at anatomical position, and then move our arms out to the sides like this. That's abduction. So starting here, and then I move my right arm off away from the midline. That's abduction. If you think of the term abduction and how it's used in everyday language, you can think of an example of, say, the child's been abducted from his parent, taken away, right? So this is movement, again, away from the midline. Adduction is just the opposite, where we are bringing a limb toward the midline. That could, again, be a leg. It could be an arm. Those are the two most common examples I can think of. Or they do mention spreading the fingers or toes away or toward one another. So we could have abduction or adduction that way as well. Generally, I think of an arm or a leg. Flexion and extension. Imagine here at the knee joint an angle, which here appears to be, we'll just call it 90 degrees, as opposed to if the leg is straight out, that'd be 180 degrees, right? So during flexion, we're taking and we are decreasing the angle between, in this case, the lower leg and the thigh. If we start off with a fully extended leg, that would again be 180 degrees. If we bring our leg toward our buttocks, let's say, that angle goes from 180 to 150 to 130 to 100 to 90, like we're seeing here, approximately 90 degrees. So if the angle is decreased, we have flexion. If the angle between the bones at the joint is increased, we have extension. This happens to be full extension. The leg is straight out. So when a football player goes to kick a field goal, he or she initially must flex his or her leg before he or she extends it to kick the football. The other way that I remember flexion and extension, especially extension, is when you think of extending a greeting to somebody as you go to shake their hands and as you meet them at a get-together. Okay, so when I extend my hand as a warm gesture, glad to meet you, that's extending, extension. I'm increasing the angle. Flexion, again, being just the opposite, where the angle is decreased. Hyperextension is often used to describe an abnormal extension beyond the normal anatomic stance. Now, if you hyperextend your leg or your arm, that could often result in injury. Okay, so typically, a hyperextension is not a good thing, generally, because it pertains to some sort of an injury where you've gone beyond the 180, let's say. However, we don't necessarily have to injure ourselves as we hyperextend our hand. Okay, so if we go beyond the 180, that's hyperextension. If we bring the angle such that it becomes less, that again is flexion. So flexion, extension, hyperextension, going beyond the normal range. Dorsiflexion and plantar flexion relate specifically to the foot at the ankle. So when you, say, walk on your heel with your toes up in the air, that is called dorsiflexion. Dorsiflexion. When a ballerina dances on her tiptoes, that is plantar flexion. Where we take the heel off the ground toes planted. That's plantar flexion. Okay. You can watch this little video. It talks a little bit about the, I think this reviews the plantar flexion and dorsiflexion movements. Circumduction is where the joint, as the articulation occurs at the joint, we in essence sketch an artificial circular path, as you see from this diagram. It's sort of like drawing a cone, where the top of the cone is the fixed part of the elbow, and the hands here defining the bottom of the cone that we're kind of drawing, an imaginary cone that we're drawing. So the top of the cone stays stationary, somewhat stationary, but the bottom of the cone we're drawing with our hand. We could also illustrate circumduction by moving our finger, right? Think about that. As you circumduct, you're etching or sketching an imaginary cone. Supination and pronation are relating specifically to the hand or palm. During anatomical position, which you all know is standing with the palms facing anteriorly forward, the hand would be in the supine position. If I were to move my hands in such a way at an anatomical position, then I would be talking about having pronated my hand. Now, the way that I remember the difference between these two is I think of a bowl of soup. You hold a bowl of soup in the supine or supinated position. Supination, pronation. Protraction, retraction, moving a part forward or backward. Using the example of moving the jaw forward or the jaw backward. Or the head, I should say, not so much the jaw, but the head. Moving the head forward, protraction, backward, or retraction. Elevation and depression. Elevation, something that's high in elevation, so it's high up, raising a part, lowering a part, depression. I'm depressed. Elevation, depression. Think of shrugging your shoulders or drooping your shoulders. Okay, there is a supplemental PowerPoint that I've posted in Blackboard, which has some descriptions of these various movements. I would give this a shot if you're interested in checking those out. Sometimes they seem to load for me fine here in the office, but when I do it at home, it doesn't seem to load. I'm not sure if it's a function of having access to some files here at my desk and not having that at home, and that's why they play. So I would say give it a shot, see if these various slides work for you. That's why I put them in here. They play for me in my office, but I think there's been some issues in the past. But I threw this slide on here just to kind of tell you, give it a shot if you're interested in checking those out. And that pretty much wraps up Chapter 8. Now, the last part of Chapter 8, Section 8.3, I believe it is focused on specific synovial joints, getting into the anatomy of the shoulder, the elbow, and the hip, and the knee. And I'm not going to ask you anything on that on the lecture exam. We did spend some time on the knee joint in lab recently. So if you want to reference that section there in your book on page 282 through 285, there's some nice sketches there as it pertains again to lab. There's also a couple of clinical application boxes, I think, in this chapter, one on 286, 287. Don't forget about those. But this pretty much wraps up chapter 8.